Cauda equina syndrome. So the cauda equina is a group of around 20 nerve roots that originates from the conus medullaris at the base of the spinal cord. And it actually begins around L1 or 2, but can sometimes be a little bit lower. Cauda equina compression is most commonly as a result of disc prolapse, but can also occur due to any space-occupying lesion, such as malignancy or trauma as well. It has an incidence of approximately 0.04% of low back pain in primary care, but 0.4% in ED, again, so roughly 10 times more common in an emergency care setting. And it's reported more frequently in females aged 30 to 49, although the evidence is mixed and can occur in any patient group. Approximately 70% of cauda equina patients have chronic low back pain. So you're not always looking for an acute episode of back pain that's a new onset. In fact, that's actually less common to find it in the acute population. So don't dismiss someone who's got chronic back pain for having cauda equina. In terms of screening, the patient's subjective history is the most important aspect of the assessment for cauda equina. And this card is given to patients in the NHS in England, which is quite good. It's fairly comprehensive, and it lists all of the questions that might indicate someone has cauda equina syndrome. So the basic questions to ask, I think, are, have you had any changes to your bowel or bladder function recently? Any episodes of incontinence or changes in sensation around your saddle area, or when you're wiping after going to the toilet? And some people might not know what the saddle area is, so you can kind of gesture to give them a bit of an idea. If you do get a positive answer to any of these questions, it's really important to dig deeper and try and determine whether this is a new thing, whether it's more chronic, and if you have any suspicions, again, getting that investigated early is important. A big warning sign that someone is developing cauda equina syndrome is unilateral radicular pain that progresses to bilateral radicular pain. And that's always something that you want to escalate to get investigated very quickly. Down the bottom here, you can see this is another NHS decision-making algorithm that's probably worth having a look at. It discusses symptoms, imaging and management, and provides a click-through flowchart depending on the patient's presentation. You can even work through with the patient in front of you. There are three main clinical patterns of cauda equina syndrome. First, there's the rapid onset in the absence of prior back problems, so the acute onset type. Second, you'll have acute bladder dysfunction with a history of back pain with or without sciatica. And thirdly, chronic low back pain and sciatica with gradually worsening pain combined with new bladder or bowel dysfunction. Like I mentioned before, you've got to be just as cautious or more so of the people with chronic back pain that have changes as you do with the more acute presentations.